So this is the third video of the common dental indices, and in the third video we're really going to hone in on the different caries indices that are out there. And the caries indices are much more standardized and are much more commonly used in dental research. It's not as subjective overall. So let's focus in this video in the caries indices. So the biggest caries index that we utilize is the DMF index, and that should ring a bell to you because we're utilizing the DMF index in our clinic when we're doing a caries risk assessment. It is an irreversible index, meaning that it is looking at a disease where we can't go back to normal. So it has to be taken care of, and we can't basically reverse dental caries. Another part of the DMF index is that it is really looking at the entire caries experience. So it's not just looking at active decay that's going on at that one single point in time when you're looking in someone's mouth. It is looking at the history of caries as well, in the form of whether they have missing teeth due to extractions based on the fact that they had bombed out teeth, or if they've had fillings done in the past. So they're looking at the whole total caries experience, past and present. The DMF indices are also only used to score coronal caries only. There's a separate index that will look at root caries. And there's two different DMF indices that are out there. There's the DMF-T, which just uses teeth, and you look at the teeth as a whole. And then there's the DMF-S, where we're looking at the different surfaces on each tooth. The DMF-S gives us a lot more data. It's a lot more sensitive of an index, but it's a little bit more cumbersome to use. So typically the DMF-S is used for cohort studies as well as clinical trials. And we see the DMF-T used a lot more to determine prevalence of dental caries within a population. So what does the DMF-T and the DMF-S stand for? The D is actually decay. So any tooth or the surfaces of the teeth that have decay in them that are restorable through fillings or composites. And it also includes recurrent decay. So maybe there's already a filling there, but we have some recurrent decay that is around that filling. The M is missing due to caries, and due to caries is really, really an important part of that. If it's missing for other reasons, it doesn't count for this missing component. So if it's missing because somebody got a tooth extracted to make a little bit more room for orthodontics, then it does not get counted into this missing category. The F is filled, so they have some type of filling, whether it's a composite or an amalgam, in the tooth or some of the surfaces with no dental caries present. And then the T, like I said previously, means teeth, and the S means surfaces. So if you're looking at a posterior tooth, there's 5 surfaces that you count and you assess. So you're looking at mesial, buccal, lingual, distal, and occlusal. And then on anterior teeth, if you're doing a DMFS, then you are looking at 4 different surfaces: the mesial, the buccal, the lingual, and the distal. So in the DMFT, you only count a tooth one time when you're utilizing the DMFT. So if you have decay on the occlusal surface and then you have decay also on the buccal surface of number 3, you're only going to count that tooth once in the decayed category. Now, if we were doing the DMFS and we had decay on the occlusal surface and decay on the buccal surface of number 3, we're going to give that a score of number 2 because you have decay in 2 different surfaces. If you are doing the DMFS and you have a tooth that's missing due to caries, then you're going to count that as a 5 if it's a posterior tooth in that elm category. If it's an anterior tooth, then of course you're going to count that as a 4 because there's only 4 surfaces on the anterior teeth. Of course, the DMFS is a better assessment of the extent of caries experience. The biggest problem with the DMFT and the DMFS is that it doesn't really differentiate between how severe that caries is in the tooth. Is it a bombed out tooth, or is it just a little tiny little stick in a pit on the occlusal surface? So it doesn't really differentiate between those types of things. So the scoring, here are the rules for the DMF scoring. You can only score a tooth or a surface in one of the categories. It can either be a D or an M or an F, but it can't be any combination of those. So if you have a tooth that has a filling in it and it has active decay, then we're going to count that as a decayed tooth and not as a filled tooth. So it only goes in one of those categories. Only teeth that are extracted or restored due to caries are scored. So any other restorations that happen that are not due to caries are not scored in the DMF part. Some other things that aren't scored, obviously teeth that are not erupted or congenitally missing teeth are not scored simply because they're not there. We can't assess them. Third molars are not scored in the DMF at all, simply because it's really hard to tell whether a third molar was extracted because there was decay in there or whether there was some impaction going on, those type of things. So they just really, for clarity's sake, leave third molars out. Again, teeth that are removed for other reasons are not scored in the DMF. Teeth that are restored for trauma, preventive, or any kind of aesthetic reasons like veneers or sealants or any kind of bonding, those aren't scored in the DMF because it's not really decayed. And then they don't score retained primary teeth with permanent successors present. So if you have a primary tooth and a permanent tooth present, they don't score those. So let's say we go out in the community and we do a DMFT. So it's a small, very small community that we're looking at the DMFT on. And we gather data at the very beginning, and we notice that within this population, they have a D score of 8. They have a missing score of 1 and an F score of 2. So they have a total DMF score of 11 here. So we introduce a intervention, a caries health promotion program, right after we do the pretest. And then after a year, we go back and we collect data again. And we notice that our decayed category is now a 2, our missing category is now a 3, and our filled category is now an 8. So our total DMF score is a 13 here. My question to you was the treatment successful? Was the caries health promotion program successful? Treatment, I would argue that, yeah, treatment was very successful, simply because the active decay that we have has decreased. So we've gotten people out of active disease that was present. Inevitably, the missing category is going to go up, especially in dental public health programs, because typically we're seeing decay that is pretty severe out there. And then inevitably, if we're fixing the decay, then our F category, our filled category, is also going to increase. There should be a slight increase in the overall DMFT, and that just generally occurs over the long term simply because we tend to be doing more of those fillings types of things. So we can look at the DMFT or the DMFS in terms of the individual, like what we do in the clinic when we're doing the caries risk assessment, or we can do an average DMFT or a DMFS for the total population. Some other ways that we can report our DMF data is that we can obviously do the counts. So we can say this population had a total D score of blah, 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 or a total F score of X, Y, and Z. So we can give the count of the diseases or the statuses that's going on within that population. We can also give the proportion of what's going on, what category that we're really interested in. So we can give the proportion of decayed compared to the total DMF scores. We could also look at the total count or the proportion of teeth that have been restored or treated. So we would either look at just the F category or the filled and the missing category combined. And then you would divide it by the DMF score, the total amount, the count there. So let's say we do an examination, and I'm using the term examination loosely here. So we do a clinical screening of 100 people. Let's say we do a clinical screening of the D4s. And what we found was that of the D4s, of those 100 people, we found that there was 96 decayed teeth. We found that there were 15 missing teeth that were due to caries. And we found that there were 25 filled teeth. So the total DMFT score would be 136 because we're adding those three categories together. Now, if we wanted to get a proportion here, then we would divide it by 100 because 100, we have 100 people in our population. So then we would have the average number of DMFT. It would be 1.36 DMF for this population. Now, if we looked at, let's say, the D3s, we did a clinical screening of 100 different people. So let's say that there's 100 D3s. So we're looking at the D3s, and we found that they had 18 decayed teeth, 26 missing teeth, and 92 filled teeth. And those missing teeth are due to caries. So we would add up the D, the M, and the F together again, and that's 136. So we'd have that count. And then, so 136 decayed, missing, or filled teeth. And then if we wanted a proportion, we would divide it by 100, the population. And then again, we would get a 1.36. So what's our conclusion here? Which population is healthier? You can't just look at the total DMFT scores and then or proportions because they're the exact same in these two populations. So our D4s and our D3s are the exact same. We have 136 DMF Ts or if we're going to do a proportion, we have 1.36. We really have to look at the subsections here. So the second group of people, the D3s, are actually a lot healthier because they're not in active decay. We see that they have a lot of past decay, but they have gotten those filled. So they've gotten the decay, they've gotten the disease taken care of, basically. Of course, the missing teeth are going to be a little bit more, some compared to the first group, the D4s, simply because typically in public health, people are having a lot more extensive decay that would indicate extracting the teeth as opposed to filling them up. So, because their teeth are filled, they don't have active decay. The second group, the D3s, are much healthier. So if I were a company or if I were developing a caries prevention oral health model, then I would target the first group, the D4s, because those are the people that actually have a lot more active disease going on. So notice that in the DMFT and the DMFS examples that we've been talking about, they're all capital letters. Know this rule of thumb. Capital letters means big people. Big letters, big people. So big letters, adult people. What about kiddos? When we have lowercase letters, small letters, know that we're talking about kids. So that's how you can differentiate here. There are a couple of different caries indexes or indices that we can use for primary teeth. We can use the DEF or the DF. And usually the DF or the DEF are the two indices that you can utilize for mixed dentitions. So the DEF, same kind of categories. The decayed means, obviously an active carious lesion, and then the F still means filled. But the E is different. So notice in the adult, the DMFT or the DMFS, we have the ILM, and that's missing due to caries. The big difference between adults and kiddos is that we don't have the missing section for the DEF or the DF. It's an E, actually. So basically, the E means extraction is indicated due to caries. So it doesn't mean that it's already been extracted, and it doesn't mean that it's already been exfoliated. It means that that tooth is so bombed out that it needs to be extracted. So that's what they count in the E section. Missing primary teeth are ignored simply because it makes it a little bit less reliable if we have to go on patient report as to why they're missing that primary tooth, because it could have been really naturally exfoliated as opposed to being removed for some other reason. So if we include missing primary teeth, then we're really kind of skewing the data with the DEF because it can really understate the true carious extent within that population. The DF is a modification of the DEF, but basically it's just kind of eliminating that E category. And all teeth are going to be, if there's carious lesions, it's going to go into that D section or category. And then if it has a filling or a composite or something like that, it's going to go into that F. This really increases the reliability simply because sometimes the scoring of the E category can be a little bit subjective. Now, if you have kiddos that are toddlers or preschool age, and they have all their primary teeth, we use the DMF. So the DMF is basically used before the age where they start exfoliating their primary teeth. And when we're using the DMF, we're only looking at the primary molars and we're only looking at the canines. So some limitations of the DMF or the DEF. It really combines, because it's a caries experience type of index, it combines treated and untreated diseases. So you really have to do additional math to separate the different components out if you want to be able to report that. The missing component is really difficult to assess, especially if you have to go based on patient report. If you're utilizing this data to be able to make some oral health promotion changes and policy changes, sometimes the DMF data can really be detailed, and sometimes it's really difficult for non-dental people to understand, especially those people that are in those positions of power that can make those policy changes. You know, if you have any experience of working with patients in the dental office before, you know that a lot of people don't really know the difference between a filling or a cavity. You know, I've had several patients that will point to an amalgam filling and tell me that that's a cavity that they have going on then and there. They don't understand that they have taken care of that disease and placed something silver in its stead. The DMF and the DEF, so both the primary and the adult versions of the caries index here, can only be utilized for dental professionals because it does require higher degree of clinical judgment. And a fifth limitation of these indices that I didn't note up on this particular slide is that it doesn't differentiate between extreme decay and like a little tiny stick of decay, like some pit decay. So a lot of times it doesn't differentiate between the severity of the decay or the extent of decay. Now, I told you that the DMF and the DEF caries indices was for the coronal caries. So we do have a separate index for root caries, and this is the root caries index, or the RCI. So it only includes the teeth at risk in calculation, which are teeth that have recession. So you have to have recession to have exposed roots to be able to develop carious lesions. So this is the formula of how you calculate the root caries. So you look at decayed and filled root surfaces, and then you divide that by decayed, filled, and sound root surfaces. So the total root surfaces that have been exposed. And then you multiply that by 100 to be able to get a percentage. So you can express that, or you can note that as a percentage of decayed and filled root surfaces. So those are our caries indices. Those are much more commonly used out in the field. You'll see those used and noted a lot within the research articles that you read. So now you know how to interpret them. So in the next video, we're going to look at some of the other indices that are out there and wrap up this section.